See a couple of folks coming in the waiting room that Jennifer is in the process of letting in. So thank you everyone for being here. I'm not sure how many folks are in Ottawa, but we were all awoken to a blanket of snow on our lawns and streets and everywhere else. So yeah, we had, some of us had thought that that was it for the snow, but we'll see. Hopefully it's starting to melt and it'll be gone before the end of the day. So on that note, my name is Sean McKenney and I'm president of the Ottawa District Labor Council. I'll start with the land acknowledgement. We are coming together today from our homes and places all across the Ottawa region and Ontario in honoring the ability to gather. We recognize the First Nations, Métis and Inuit peoples who have inhabited and cared for this land for many millennia. Part of each of our reconciliation efforts compels us to know and understand our colonialist history, the devastating destruction it has caused, and ways it continues to damage the lives of many. During this COVID-19 pandemic, we witness an even clearer view of the disparities in our shared space and work diligently each day to ensure the prosperity of all peoples. So on that note, as I indicated, my name is Sean McKenney, president of the Ottawa District Labor Council, who along with Laura Lazansky, who I'm gonna hand it over to in just a moment, will be co-facilitating for the most part the session this morning. The Labor Council, for those that aren't aware, is one of about 110 labor councils from across the country. In Ottawa, we have approximately 85 affiliated union locals representing about 50,000 working people. We work, I'd like to think, pretty hard with the occupational health clinics for Ontario workers, the Ottawa area, the Eastern Region Clinic. I do sit on the local advisory committee that Laura's going to talk about that. And again, the importance of labor councils, of labor and unions, because there's so many similarities with safety, with workplaces and unions. And I think that's fact. So it's certainly something that we find in Ottawa, and I know elsewhere as well, really important. And that's that relationship between OHCOW and the Labor Council. So we've got a pretty jam-packed day. And again, I want to thank you all for participating. So with that, I'm going to hand it over to Laura Lazansky. Laura?
Thanks so much, Sean. My name is Laura Lazansky, and I'm the chair of the local advisory committee for our Eastern Region OHCOW Clinic. And along with Sean, we're going to be your hosts for today's session. And as Sean pointed out, we have a very large catchment area, and we have 7 labor councils in our catchment area. The Ottawa one is the largest one, but we have 6 more who we're actively working with, because workers, wherever they are, need to know where their resources are, and OHCOW is an excellent resource for both workers and their workplaces. So I will be talking about some logistics in a few minutes, but first I'd like to introduce David Chezzy. He's president and chair of OHCOW, and David's played a pivotal role in ensuring that OHCOW, its clinics, staffs, and LACs are engaged and supported to carry out their very important work on behalf of workers and their workplaces in Ontario. David, could you say a few words, please?
Sure. Thanks, Laura. Thanks, Sean. Welcome, everybody. And I'm really happy to be here today on behalf of the board. I want to just extend a few thank yous, of course, to the Ottawa District Labor Council and Sean and all of the efforts from all of your staff and folks over there, as well as our LAC, our local advisory committee here in Ottawa, at this great event that couldn't have been done without the helping hands of many that sit on our local advisory committee. If anyone is interested in becoming involved or thinking of wanting to be involved at a local level with OHCOW, Laura is the one to speak to. Thank you, Laura, for all the hard work, you and your committee. Thank you to all the staff, not only the ones that are going to present today, but all of our staff in Ottawa and at our other clinics, they all work in a cooperative effort model, and together we're able to do things like this for you. And thank you to all of you, the participants. There's many of you online today. We have many loyal followers, if you will. Many of you, if this is your first, well, welcome to the event that the Ottawa Local Advisory Committee is putting on with the Labour Council. But there's also other ones that we put on different times of the year. We have our Repetitive Strain Injury Plus Days. We have our October, celebrating Oc Disease Month. We have our May Day events that are coming up, and many others really that we're able to put on for you. And I want to thank everybody. I see there's people from, and I can say all across the country, because we do have people from afar as well as people close by. So thank you to all of you afar, and thank you to all of those of you who are joining us from the local surrounding area in Ottawa. I want just to quickly say that I'm here with my little mascot friend, our OHCOW cow. He's a pretty popular little fellow. But what we do at OHCOW is we provide a multidisciplinary team of health professionals that can give you knowledge and can give you advice and can do things through advocate referrals. We have doctors, we have ergonomists, we have hygienists, we have our client service coordinators, we have our other staff, our executive directors, et cetera. But all of these people in these multiple disciplinary teams can provide services to you on a one-on-one basis, on a union to union basis or a non-union basis, for any of the healthcare needs that you might need that face your health and safety issues in your workplace. And the wonderful thing that encapsulates all this is that our services are free. So it's at no cost to you. And I just want to let people know who use our services as Wsib advocates that our doors are still virtually open. We haven't been able to physically open just yet. We're on the brink of hopefully a change in this gosh awful pandemic that we've been in for too long. But we will still accept files. We will still accept referrals. There are staff that go into clinics periodically, to do our health and safety checks and things of that nature, who can make arrangements to receive files and virtually and electronically for those of you who are looking to have those special cases looked after by our team of health professionals. Please don't hesitate, contact Kimberly. You'll meet her later on. You saw her this morning, who's our executive director, and she'll find ways, along with Cheryl Baker, who's on the line, our client service coordinator in Ottawa, who can do all that for you. The other thing that we offer that is, again, free and really open and accessible to you is our website. And it's really simple to get to. It's our acronym OHCOW.on.ca with a triple W before it. So www.ohcow.on.ca. And I see that Kimberly has put it in the chat for all to get to easily. We have all of our past webinars, our past presentations on the website under resources. You can click on that and you can wander through and take what you will and bring it back to your local affiliations and present it to your members. So if you've missed any of our webinars, take advantage of going back and taking a peek at those. And as well, we have a resource that comes out now more than just quarterly. It's called the newsletter called The Lens. And at the homepage of our webpage, if you scroll all the way to the bottom on the right-hand corner, there's a sign-up sheet for electronic access, and we'll send that to you to your trusty little email boxes every time we produce it. And as well, look forward to what we are going to call the Advocate newsletter, where if you're a WSIB advocate or health and safety advocate, there'll be special things that are more tailored to your needs than just general information that OHCOW has to offer. Keep your eyes peeled. We're hoping to launch that very soon. So on behalf of the board, I just want to say thank you all for joining today and enjoy this session. This is for you. It's one where we're going to spring into action very shortly with this exciting agenda. And I want to thank all the presenters. And please, there's going to be time for a Q&A. It's interactive. Please don't be afraid to ask your questions. That's what they're here for today. So thanks to all the presenters that you're going to hear from today, Daryl, Trevor, and James and Margaret. So thank you all, and back to you, Laura.
Thank you very much, David. That was a great overview of our OHCOW services and supports. Okay, just to draw your attention, the session is being recorded right now. It started a few minutes ago when Sean started, just to let you know that. Once the speakers begin, you will be muted, and you should probably have your screens off unless Jennifer is going to do that automatically. So I just wanted to indicate our really close work that we've done with Sean and the ODLC, who've helped to organize, fund, and host the events when we used to have them in person here in Ottawa, but also being a great support virtually through the pandemic as well. And so the Labour Council is doing the virtual support today. I'd just like to take a brief moment to introduce our LAC board members, some of whom are here today, some of whom couldn't make it. So Leanne Feltham from ETFO, Kim Manette from the Ottawa Hospital, Mark Balland from PSAC, Richard LeBlanc from USW, Olivier Melanson, QP Young Worker, Alia Mofford, Office of the Worker Advisor, Debbie Scribbins, Community Representative, Aaron Smith from QP, their WSIB officer, Clarence Wallace, our WHSC, our Workers' Health and Safety Center representative, Kimberly O'Connell, who's the executive director of our clinic. And then I'd like to give particular thanks to all of our wonderful OHCOW staff who do amazing work and give us support and information, and whom we rely on quite heavily for particular health and safety information. And then finally, Cheryl Baker, who's the Client Service Coordinator at OHCOW, and Jennifer Moore, administration at the Ottawa and District Labour Council, who provides us with all the amazing support for all the work that we do, whether it's for this conference or for other meetings. We couldn't do this work without these wonderful sisters, and I'd like to take a moment just to give them special thanks. So a bit of housekeeping, and then we'll get started. So Zoom, if you're having any issues or questions, please contact Jennifer through the chat. If you're having any bandwidth issues, please feel free to turn your screen off at any time. You'll be muted during the presentation, as I said, but then the mute will be turned off when the question Q&A comes. I'll be monitoring the timing as we go. And a final reminder about the link for the post-session evaluation. Please take the time to fill it out. It really helps us not only to plan our future sessions, but also helps us understand how we can better help you participate and attend. So please take a moment to fill that out. Our final guest speakers, Jim Brophy and Margaret Keith, have generously donated a copy of the book they co-wrote with Michael Hurley, which they'll be talking about in their session, Code White, Sounding the Alarm on Violence Against Healthcare Workers. And there'll be a draw at the end of today's forum. Please stay tuned for a minute or two at the end to see who's the lucky winner. Finally, there's a break at 10:45 for 15 minutes. Please be back promptly at 11 o'clock for our last speakers. So now I'd like to introduce Kimberly O'Connell, who's the Executive Director of our Eastern Region OHCOW Clinic, and she brings a wealth of knowledge, guidance, and expertise to our LAC. We all find that her energy and support helps keep us focused and helps us look for creative ways to help the clinic support our catchment area. So Kimberly.
Good morning, everybody, and thank you to this amazing group of the Ottawa District Labour Council and our local advisory committee, and our president and chair, David Chezzy, for the kind words. They always do such a good job that I say, you know, just let me introduce the first speaker, because really what OHCOW, or Occupational Health Clinics for Ontario Workers, is about is all of our amazing team from the folks you've already met to the ones that said hello, that are the power in the back making all this happen, and all across the province. And you're going to get to hear from a couple of them that aren't in the Eastern region today, one from the North and one from Central. Yeah, it's just such a great group of amazing interdisciplinary health professionals. Our occupational health nurses, Tracy's on the call, our physicians. I think we have a physician from the ministry on the call, so thanks for coming. Our ergonomists, our client service coordinators, and our occupational hygienists. I happen to be one of those and lead out this amazing group. So it's always my pleasure to introduce our full of knowledge staff. And I'm going to start today with our first speaker and round out the day. So Daryl Stevenson is graduated from the University of Windsor in 2008 with an honors Bachelor of Science degree in human kinetics and specialization in the field of movement science. In 2011, he graduated from the University of Windsor with a master's degree in the field of exercise physiology. In 2018, he graduated from Western with a PhD in health and rehab sciences. So Daryl's recognized as oops, something just happened to my computer, of course. I'm still with you, an associate ergonomist through the Canadian College for the Certification of Professional Ergonomists. And he's a member of the Association of Canadian Ergonomists, or as we friendly know it as ACE. Daryl's been an ergonomist with Occupational Health Clinic for Ontario workers for 4 years, but Daryl did his PhD on the underreporting of concussions in the CFL, and he doesn't put it in his bio, but he was a CFL player, which is, you know, he has lots of experience in this, both, as you can see, from an educational perspective, from on the ground, or on the field, should I say, perspective. So welcome, Daryl.
Thank you, and thank you for having me. So I'll try to share my presentation here and make sure. Okay, so do you see it? Yeah, good, okay. It's the big screen, it's not the presenter view. Yeah, okay, good. One time I did it with the presenter view. Okay, so my name is Daryl Stevenson. I'll probably turn my video off just for, well, if it's okay bandwidth wise, I'll leave it on. So my name is Daryl Stevenson. Thanks a lot, Kimberly, for the introductions, and David. You know, really happy to be here. I was part of this a few years ago, and it's a great event. Today, I'm going to be talking about concussions, post-concussion symptoms, underreporting, and prevention of workplace hazards. So as Kimberly discussed, I did do quite a bit of research on concussions with my PhD. Not just my own project, but other projects that I was working on. So I have a good knowledge of concussions, but I also, as a CFL player, I had 2 concussions that I went through. I went through the process, and those were in my first, second and third year in the CFL, and I ended up playing another 3 years after that. So I made through the recovery and got through, but yeah, so I definitely have some firsthand experience with it. And that was a lot of the reason why I went that way with my PhD that I did after I played in the CFL. So I kind of, you know, it was important to me, and it was something that I really wanted to understand better because I was living through it. And it led me into that research. So for the presentation outline, I'm just going to be going over some information about concussions, some of the long-term effects, some of the underreporting or workplace factors that might contribute. I'm going to be going over preventing the workplace hazards using OHCOW's Hazard Assess app. And the goal is to raise awareness and to promote steps to take action to prevent concussions. So the 5th consensus statement on concussion in sport, held in Berlin, describes a concussion as a traumatic brain injury induced by biomechanical forces. And this is produced by acceleration and deceleration forces that are acting on the brain, which may be linear and rotational, or which may be linear or rotational. And while concussions are typically a short-lived event, many of the times that there can be a variety of symptoms, and these symptoms might vary substantially across individuals in the severity of them. So here's just some illustrations of what kind of happens with the concussion. It's just not the initial impact, but the bounce back effect, the contra croup injury. So you can see in this picture here to the top left, you hit the wall, and then there's that reaction force. And this video kind of a little disturbing, but it summarizes a bit that impact. So I had those two pictures in that video. And then I showed Trevor Shell, the next presenter, and he overnight came up with this really incredible image. So just showing the effects. So you hit the wall, and that movement in the skull with the brain is what's going to cause those issues. So that's why when you look at things like, even if you have a helmet and it stops that initial blunt force to the skull, there's still that movement. The brain still can move in there. And that's what's going to cause these problems. So really cool image by Trevor that somehow he made overnight. And you'll see in the next presentation, he's got some really neat images. So there's been an ambiguity in the definition of concussions and post-concussion symptoms. There have been a variety of terms used interchangeably, such as mild head injury, mild traumatic brain injury, and cerebral concussion. And you'll see often, especially within the scientific literature, a lot of times it just says concussion / MTBI. So a lot of times they are used interchangeably. But there's also many slang terms that are used, and these are used in the lay literature, in news reports, but also a lot in workplaces or in sporting events. So things like being dinged or having one's bell rung or seeing stars is a very common thing, especially, when I played. It was common to hear, I got my bell rung, I was seeing stars for a bit, but I'm okay now, right? And what these slang expressions, why they're kind of bad, is because they really downplay the severity of the injury, and they kind of normalize the injury. So it's important to stick with the language, and we've asked people, what would be the difference if we said that you were dinged, or you had a concussion, or you had a brain injury? And really you respond more to that brain injury. So it's important not to use these slang terms when you can. So concussions occur when the brain is injured after a traumatic event, such as a blow to the head. However, you don't have to actually hit your head to suffer a concussion. And this is one interesting part about concussions that's commonly misunderstood. Even when I was interviewing CFL players, this was a commonly misunderstood issue. So it's possible to have a concussion due to whiplash or rapid rotation or shaking or jerking of the head, or even just the body. So it's very important, because somebody's working in a factory and it has vehicles moving around, storage vehicles, and a vehicle bumps into somebody in the side of them, they fall down, they never hit their head once. But then, later in the day, they start having headaches, neck pain, and they don't think this could be a concussion. I never got hit in the head. Maybe it's just my neck is sore, or different things like that. So understanding that you still can get a concussion without getting hit directly in the head is very important. It also doesn't require a loss of consciousness to have a concussion. And very importantly, in some cases, the signs and symptoms are delayed and will evolve over a number of minutes to hours. And that has a lot of implications for how to react to a concussion and how to deal with the recovery. Because it's very important to know that what you're seeing now might not be what you're seeing in the future. And throughout your recovery, this can be a big deal. So there's quite a large list of potential consequences from concussion. As we saw, that whole brain movement, and your brain controls so many things that, any part of those that can be disrupted can cause problems. So there can be problems with things like cognition, memory, judgment, communication, or how they move their body, how they control their body in space, their coordination and balance, or even their strength output. Okay? There's sensory issues, vision, hearing, things with their touch, smell. I've even heard of people seeing different colors after a concussion. And then social relationship issues. So anything communicating with others, being in large groups can cause a lot of problems. So there are many common signs and symptoms that are associated with concussions, and this list continues to grow. And as I look through different resources and websites, it just keeps getting more and more and more. So I just present as many as I can here, just to show that there are many different symptoms that you might not really think of. So the common ones you might think of are like headaches, dizziness, seeing stars, even nausea. But then there's other ones like poor concentration, easily distracted, not participating well. And it's really tough to monitor those. So it's important to be aware of those. When we played in the CFL, it was in 2011, they came out with a big push for concussion awareness. And what they did, they put life-size, I mean, these are 10-foot posters in every single locker room that had every single symptom, sign and symptom, so that you're constantly getting more awareness of these. So again, just overall, depending how you're looking at it, as this picture demonstrates, there's various ways a concussion can be labeled, not only in an overall term, but as to what is happening and the resulting implications of the concussion. So depending on what you're looking for, it could also be a combination of many labels or problems. So because the duration, symptoms, and diagnostic testing and treatment in each case are so varied, concussions can be very complex and costly to treat. So it is, however, very hard to predict the end result from the initial impact that caused the concussion. So in that way, concussions become more about monitoring and reacting to the symptoms that show themselves. So recovery is typically from days to months, but can last over a year. And the majority of workers with concussions return to work within 1 to 2 weeks following the injury. So early physiological symptoms such as headaches can turn into psychopathological issues such as anxiety and hypersensitivity and depression. And this is due to microscopic physiological changes that occur post-concussion that can have delayed secondary implications. So there are some factors that have been shown to be associated with poor functional outcomes, and this is directly after the event. So something like dizziness, the number of symptoms, post-traumatic stress, pre-injury work history, loss of consciousness. But again, this is going to be very variable, and I even hesitated to put this up. But yeah, just know there are some, more severe instances. But again, the overall way to approach it is going to be to be cautious and try to monitor the symptoms and treat it all like it's a bad concussion to start with. So symptoms of a concussion can be persistent for some individuals, though a consensus has not been really reached on the cause of long-term PCS. It's likely that biological, physiological, psychological, and social elements all play a role in the persistence of the symptoms. So suffering from PCS-related symptoms for an extended time may delay an individual's return to work, affect their quality of life, and result in additional social and economic costs. So this is after, so during the recovery. So some factors that may contribute to persistent post-concussion symptoms. And this just sticking with that topic of these persistent symptoms. So things like medication-induced fatigue, headache or migraines, vertigo, sleep hygiene, alcohol use, and depression may contribute to those persistent symptoms carrying on. So up to 80% of people who experience moderate to severe concussion symptoms may develop post-concussion syndrome. Post-concussion syndrome can involve a cluster of symptoms such as memory loss, headaches, vertigo, cognitive delay, depression, fatigue, and this would be similar to having many persistent symptoms. So before we were talking about those persistent symptoms, and this is more of a cluster of those symptoms that continues together. And PCS has many challenges, and it can be particularly challenging for employers even and insurers, as it's hard to prove for the average insurance company. You need to have post-concussion syndrome, but all the tests that you're doing show that everything's normal. So the CT scan, the MRI, yet you're still unable to attend work, and it's very difficult. It's very difficult for sick leave insurance companies to adjudicate, and your brain is shifted in a closed cavity, and those tiny shear forces that cause the brain receptors to not fire in the same way as they were before the head injury. So it's hard to prove these things sometimes. Post-concussion symptoms can impact memory, mood, and function, but it's difficult to prove with any pre-tests. And even those pre-tests themselves can be gamed or inaccurate. And even recently, when looking through literature online, there's many sites that are saying don't do these pre-tests. And I even know from playing in the CFL and talking to those players after, they can be gamed. If you wake up, you don't have a good sleep the night before and you score poorly on your test, and then you take that test after a concussion, it might look pretty similar. And I've heard of even players that will purposely score low on it just in case they have a concussion and they don't want to get removed from the game. So it's hard for employers to understand how a concussed worker is actually feeling. And there's no visible signs as there would be with a broken bone. And there can be a challenge of identifying one's own symptoms on a day-to-day basis. The symptoms can be confusing and hard to monitor, and you're also not in a great state of mind to be monitoring them sometimes. And finally, the symptoms can return when returning to work. So even if you feel like you're good to go, you've been resting at home, you get back to work, and then your brain has to take on all these new things, and symptoms start to come up. And that's why it's generally a graded process of returning to work. And if any symptoms come up, you go back to the old stages. With professional sports, it's a week. And then if you don't have any symptoms, then you can try the next stage and you slowly work yourself up. There are also mental health issues after concussions. 1 in 5 individuals may experience mental health symptoms up to 6 months after an MTBI. In a recent study, 3 months after injury, 20% of MTBI patients reported mental health symptoms compared to 8.7% of orthopedic trauma patients, showing that concussions carry a greater risk to mental health issues. And we can kind of attribute that to what we've been talking about with all those different areas and the concerns that you might have. It's a lot less clear what the future might look like. So approximately 18 to 37% of people with persistent concussion symptoms develop depression in the first year after their injury. 1 to 2 years after the injury, this rate can double, with up to 61% of survivors reporting concussion. So the longer the initial symptoms persist, the more chances of mental health symptoms that can happen. And feeling sad is a normal response to the loss and change that a person faces after TBI. Feelings of frustration and loss are common after brain injury. And these feelings can often appear during the late stages of recovery, after the individual has become more aware of the long-term situation. And if these feelings become overwhelming or interfere with recovery, the person might be suffering from depression. So there are many mental health issues that can arise: mood swings, irritability, anxiety, panic attacks, depression, low self-esteem, PTSD, and an overall lack of energy and motivation in the interests that they had before the injury. So looking at caring for these mental health symptoms from a concussion, just in general. So when looking to resolve the mental health symptoms, some suggestions include finding the appropriate care first that can help resolve those symptoms. And this often involves multidisciplinary care in collaboration with a physician to co-manage the injuries and provide the appropriate rehabilitation. That's often the best approach, having that physician and a team. So in more serious cases, they might bring in additional support, things like psychologists or social workers to help. And it's very important with all cases, even minor cases, mild cases, to follow up after the head injury. It's crucial, especially for patients showing risk for PTSD or depression, constantly coming back and checking in and making sure they're okay, as they're going to be worried. Even if concussions clear up, there's so many things that you hear about the long-term effects that people are going to be worried, and it's important to reassure them. And that leads into that next piece: having a qualified health professional provide education and patient reassurance is very important, and let them know, take the injury seriously, but they will, give them some positive outlook on it. And then there's also the problem, I'm sure you've all heard, is chronic traumatic encephalopathy. Probably said that wrong, and I've been saying it for about 6 years. It's tough, but CTE is something that I will briefly touch on, and it's a neurodegenerative condition that is thought to have been brought up by repetitive blows to the head or concussion-like events. CTE can show up many years later in life and cause many complications day to day. And many different biomarkers are being studied, but currently one theory is that these tau proteins after injury are wrapping around the neurons in the brain and causing them to die over time. And you can see this picture, the kind of shriveling effect on the brain there. So CTE was first associated with boxing, but it's recently been found in other cases of repetitive head injury, including football and hockey players and professional wrestlers. So looking at one study with retired NFL players, they had earlier onsets of Alzheimer's disease. Those with 3 or more concussions were 5 times as likely to report mild cognitive impairment. There's a 3-fold prevalence of memory problems as opposed to players who retired without any concussions. And they had neuroimaging abnormalities relative to their age group. So there are other future concerns linked to concussion and brain injury, such as Alzheimer's-like dementia, Parkinsonism, motor neuron disease, and ALS. And once again, actually, Trevor created this image here as well. Thank you for that, Trevor. One other important thing to really remember is the second impact syndrome. And second impact syndrome is a dangerous problem that is caused when a concussion-like event happens to someone who has already undergone a previous concussion and is still having problems. At this point, the brain is more susceptible to a second injury. If the second impact happens, it can lead to worse symptoms, further brain damage, and even death. For this reason, it's extremely important to be cautious, and caution is needed after any concussion-like event, regardless of the severity. And if you think back to what we were talking about with the delayed symptoms, not really knowing their symptoms, it's very important. And I put that boxing example here as they can get knocked down and then get back up and have to fight again after they've probably had a concussion. But this is a very serious thing that's caused some big problems in sports. So just overall, now looking more at Ontario in general public. So depending on the population, the most likely event is to cause concussions are vehicle accidents, falls, sports, and recreational activities. And we can see as we get older, you start to go down in the amount of concussions due to, you're falling a lot less. I have a 2-year-old and he falls constantly throughout the day. I'm always worried about concussions. And then when you get over 66 and those falls become more dangerous, then we start to see another trend going back up. So traumatic brain injury in Ontario workers now, 7.3% of traumatic brain injuries are work-related. According to the data from the Workplace Safety and Insurance Board, there were 1,644 claims requiring time off in Ontario in 2012, which was up from 790 in 1996. And according to the Public Health Agency of Canada, traumatic brain injuries will be the most prevalent neurological condition by 2031. Okay, so now looking, that was TBI, so now on to concussions in Ontario workers. Looking at the Workers' Compensation Board reports, it was also found that there was an increase in the trend of number of concussion cases that are being reported. And there's an increase in awareness in concussions, again, due to sports, people like Sidney Crosby, and really highlighting and bringing out the awareness of concussions. So in 2013, in Ontario, 80% of TBI, traumatic brain injuries filed to the Workplace Safety and Insurance Board were for concussions, which was versus 50% in 2010. So just in 3 years, that 30% increase. Statistics reveal that the number of time loss claims for work-related concussions increased by 371% from 2004 to 2013. And in 2016, 78% of SFM's concussion claims involved time lost from work, compared with 15% for non-concussion claims. And that's a Minnesota company, but I thought it was interesting. The number of workers with concussions who receive wage loss benefits due to time off work was 10 times higher in 2018 than in 2006. So just really showing that the trend is increasing. People are becoming more aware of concussions, and maybe they thought, they were ringers or whatever, that got their bell rung before and they were okay. But now people are becoming more aware that, these are serious and they should be taken seriously. So who is at the most risk In Canada, the highest rates of workplace concussions go to transportation, storage, and primary industries such as forestry, fishing, and mining. The leading causes are similar to the general population, with slips, trips, and falls being the highest rate, being struck by or against an object, falling object, or a motor vehicle collision. And in other cases, maybe students or customers or patients or coworkers might strike or assault an employee and cause a concussion. So now looking at preventing concussions in the workplace, we want to remove any tripping hazards. We want to make sure any walkways or workspaces are free of clutter, cords, puddles, anything that can cause a slip, trip, or fall. We want to use proper signage to alert employees of things like wet surfaces. We want to keep shelves and storage areas in your workspace clean and organized to avoid knocking over objects that might fall on you, or any unintentional objects that fall. In a warehouse or storage facility, place the riskier objects on the floor or lowest possible shelving. And this is a bit of a give and take. So some of the riskier objects might be heavy ones. So from an ergonomic perspective, you know, you have to weigh out the pros and cons of that, but make sure anything that's risky that could fall on you, that could cause a head injury, is not up high where it could fall on you. So wear the proper type of safety footwear to prevent falls if you work in a slippery, icy, or any rugged terrain. So now from more of a personal level, try not to stand on chairs, desks, or tables, but rather use an appropriate step stool, access platform, ladder, handrail, anything like that to avoid falls. Use caution from when working from heights, and know how to use fall protection and any fall restraint equipment. So if a job requires wearing a hard hat, just make sure it's appropriate for the job, it's properly fitted and in good condition. But I'd like to make a big point about helmets here, is that helmets can help, but they don't stop concussions. Helmets are great for blocking that initial hard, blunt trauma to the skull, and they do reduce some of the force. But as we could see with those examples, how the brain shifts as it gets stopped. You know, if you're running full speed and you all of a sudden your head hits a wall and stops, there's no amount of cushion really that's going to slow that down. So no helmets are going to completely stop concussions. And if anybody could create a helmet that could stop a concussion, they would be a billionaire, because every sports business and company would take over that. So really important. They're not, you know, they're there to protect you, but don't think, oh, I had a helmet on, I probably don't have a concussion, I'll be fine. Just be aware of that. Report all unsafe conditions to the nearest supervisor. And that particular step, the end part of my presentation with our hazard assess app, can actually help out with that step. So steps to take if a worker has a concussion symptom. So maybe your coworker, and this can apply to you too, but generally this slide I was gearing towards, you see somebody else have it. So the steps to take if a worker has a concussion are to alert a supervisor immediately, report the incident immediately. Again, there could be delayed symptoms, there could be all types of things going on. So it's really important to document it and create a report. Seek medical help and do not try to diagnose yourself. This is a big one. Don't try to diagnose others and don't try to diagnose yourself. You're likely going to fall back on kind of basic techniques, and that's what a lot of football players did with themselves. You know, they try to remember the date, they try to remember their name, put their fingers up, see if they're seeing blurry, and then they're like, okay, I'm good to go. But really, you know, there's so many areas that can be affected. There can be delayed symptoms. There's so many things to think about. You're really not able to diagnose yourself truly. Consult a healthcare professional to manage the concussion as soon as you can. Do not drive or let the person be left alone. That's very important. People can pass out later on, have different delayed symptoms that cause them problems. They might think that they're okay, you know, they say, oh, it wasn't that bad, I can drive home. But then once they get out on that road in big traffic, those symptoms start to come up, and they can have even bigger problems then. Don't let them be alone. In the CFL, when we had concussions, we would have people stay with that person, and they would wake them up throughout the night every once in a while just to make sure that they're okay. And then it's important to give any water or juice or any food that they can eat as soon as possible. And I was on a research group at Western with a registered dietitian and practical nurse, and they were really big on this, and that what happens with concussions is, especially with children, is that you start to feel nauseous and you want to refuse food and water. But during that time, your brain has just possibly undergone some damage, and repairing itself requires a lot of energy. And it's important to provide your brain with that energy, with those carbohydrates as fast as possible, and to make sure those supplies are up. Even if you feel nauseous, try to have something to help yourself. So now looking at underreporting of concussion symptoms, and although education is important, the ambiguity in the definitions and intentional underreporting really contribute to underreporting of concussions, and there's a lot of different factors that can contribute. So we'll go through a few of those. So concussions are often underreported across sport and workplace contexts. Every study that I've seen, it's up in the 80%. People don't report, or at least 50%, that they won't report their concussions for various reasons. So although caused by a physical trauma, concussions are an invisible injury and leaves little to no visible physical evidence. And that's an important one. It's hard to prove, it's hard to see, it's not very evident. So assessment is not as simple as testing for swelling or pain or strength, but requires an evaluation of self-reported symptoms. And that self-evaluation can be very difficult in itself. So something as simple as, what does feeling like you were in a fog mean? And that is one of the symptoms that are on all the checklists, is feeling like you were in a fog. So what we did at Western, we went to several different classrooms and asked the students to give us a description of what it feels like to be in a fog. And there were so many different responses to that. And there's a lot of symptoms that are like that, have some variability. So it's tricky. The concussed person also may not be in a good position to be assessing themselves. They might be concussed at the time and not in the right state of mind to do that. And the person may also assess the event that caused the concussion and then conclude that they could not have had one from that event. So again, not getting hit in the head, or maybe the symptoms that they felt, they didn't think that it was the same as before, type thing. So people will break down the biomechanics of what happened to them and then say, oh, it probably wasn't a concussion, but you can't really do that. So some other reasons that concussions are underreported are that people may develop assumptions about how concussions will affect them, or only attribute past concussion symptoms to possible current concussions. And that was a big one with the CFL players, is, that it was almost like, this is what a concussion looks like for me. But really, as we've gone over, it can be a number of different things, and you could have 10 completely different concussions throughout your life. So it's important not to think, I don't have a headache this time, so it's not a concussion. That's not true. So they may not have a headache this time, but when they did on their previous concussion, and they think that, and their lack of concentration doesn't have to do with a concussion, or little things like that. They may be uncertain on the strength of their diagnosis, and may be uncertain what the actual true risk to continue working is. They might think, oh, it's not so bad. I've had experiences like this in the past and I got through them working. I'll be okay this time, right? So just thinking about the past and trusting themselves. Some may work through symptoms if they're not drastic enough. And that was a big one, definitely with players, was symptoms really have to be drastic. You need a bad headache. People will work through minor headaches for weeks and take Tylenol, take other masking agents, whatever. But in the end, even those minor symptoms can be a concussion and should be treated as such. So there's also social identity issues. Depending on the workplace, this can be cultural pressure to maybe work through an injury. Obviously, that's big in sports, but definitely other workplaces that can be big in as well. They may have a history with concussions and not want to reveal this for fear of job loss or job security. And they may have financial concerns. It may be somebody who can't afford to take time off work. Maybe they get paid hourly or whatever it is. They can't take time off, so they're going to work through their injury. And with concussions, it's interesting because a lot of the times you can, in a way, work through the injury. If you have a broken leg and your job requires you're a postman, your post worker, sorry, you're going to be walking around and you can't do that with a broken leg. But you might be able to do that with a concussion, and it might just, be uncomfortable. You might have headaches, but you can get through it, and people will push through it if they can physically do it. So they may be taking painkillers, possibly another injury such as a lower back, and some of that might mask the symptoms such as a headache. One symptom of concussions is neck pain. So if you're taking Tylenol or painkillers, you might not feel that neck pain that should be an alert for you. There may be external pressures to continue to work. And sometimes this is generated internally, thinking, they want me to work, they want me to push through this, and maybe they do or they don't. Deadlines and work goals can influence people. If you have something to finish, a big contract, you're going to work through things. Stigma in the workplace or normalization of symptoms, such as having headaches after work, becoming a normal thing. And then having delayed symptoms that they don't notice right away. And again, this stresses the need to report the incidents immediately and take preventative actions. So there are limited treatment options, and there's no real best practice yet for those who don't experience spontaneous recovery. But traditionally, what treatment has meant is rest. So no computer screen, no stimuli, no multitasking, no physical activity, including sports. And that's what it was for me back in 2011 when I had my concussion. And it also means being off work, and the length of time an employee may need can range from weeks to months. But now, and a lot of the recent conferences that I watch each year, they're really big on exercise and research. There's a lot of research being done around exercise and the benefits that it can have for those who can exercise early on without increasing their symptoms. So if they can tolerate the exercise and they don't get further headaches or anything, it has been shown to help them out. But again, you need to speak with a doctor. It was even hard to put this in this presentation, thinking, what if somebody thinks, oh, I should exercise right after the concussion, and it makes their symptoms worse. So really, it's such an individual basis, but these are some of the trends that we're seeing. So rehabilitation therapy might be key during their recovery. So things like speech therapy, occupational therapy, physical therapy, or combinations. Ongoing treatments are being researched, but again, no best practice yet, as far as I have found. So, but just some general overall concussion recovery tips, things like get adequate sleep, checking with their doctor, taking things slow and gradual as you come back, and then avoiding things that can ruin your recovery, like alcohol or drugs, sleeping pills, any medication that's not prescribed by a doctor, physically exhausting activities, extensive use of the computer, television, things like that. Okay, but it is quite varied. And I did see even a report that said they're starting to say that if you don't exercise in that first 6 days, there can be other problems. So it's research that keeps evolving. So when returning to work now after the recovery, a worker could be returning prematurely and maybe put at serious risk. So even with good intentions, you might be unintentionally pushing the worker to activities that may be too demanding or stressful from a cognitive perspective. So the employee might be leaving very exhausted, they may be forgetting things or doing things without the required mental capacity. And some problems faced returning to work, and this looked at a study done in the UK, and a group of workers who had sustained MTBIs reported that some of the important issues they faced coming back to work were the invisibility of their injury, continuing symptoms that were affecting their ability to do their job, and again, not being able to really show that they have those symptoms, the lack of advice and guidance on returning to work, and in addition, the return to work support systems were considered to be poorly coordinated and managed.
Daryl, I'm just checking in on time check because I do want to make sure there's room for questions.
Okay,
sure.
How much time do I got?
Well, if we leave 5 minutes, you're close. But so just Trevor's coming on at 10, so I want to make sure.
Okay. I'll try to go quick.
Okay.
Okay. So some considerations: respect the work restrictions, reduce the physical and cognitive exertion, and gradually increment them back to work. So things like switching their jobs from physical to sedentary, or gradually increasing the amount of hours they work per week. Okay, or provide them calm, quiet areas, reduce noise levels, and ensure good commuting plans. And then be positive. Get rid of the stigma at work. It could be in a vulnerable state. Just reassure them as they go along. It's very important for their mental health. There are many validated tools. I put the list here just in case if you want to get my presentation after and you want to look up some of the tools that are out there to check with concussion syndromes. This is a good example, the Rivermead questionnaire, just commonly used. And then some references and resources. And there's a lot of good guides out there. I would suggest, if anything, if you're going to look at one, it's this Concussion Guideline, 3rd edition by the Brain Injury Guidelines Neurotrauma Foundation. So quickly, we have a hazard assess app. We have a number of apps with OHCOW that can help assess in the workplace. And these really go on the level of screening. So the frontline, the workers, and that kind of level, but also can be used a bit by the Joint Health and Safety Committees. So these apps were designed to be used by the individual. And this one that I'm going to go over quickly is the Hazard Assess app. And it runs through a checklist of 12 categories. And basically, people can download these apps on their phone and go through and check these different areas that they might be worried about. So ergonomics, unsafe conditions, chemical exposures, a lot of different ones on this Hazard Assess app. So as you can see, as you go through the app, you click which area you want to look at. So here we're looking at ergonomics. Okay, and then throughout the app, so this is my coworker, John Odike, and looking at his room, he is looking at the hazards and his exposure details. He says that there's too much clutter, my piles are falling in on me, we need to go paperless was a suggestion, and he took a picture of the room. So each individual can go around, take a picture, you can draw on them, you can write in, this is the hazard that I'm worried about, and this document then can be printed out as a PDF, it can be emailed, it can be sent through phone, it can be sent a number of different ways. Anyway, you can send a file through your phone or through email. And you can even draw on the pictures and highlight them. So it's just a good screening tool for potential problems in the workplace. And it's part of a series of apps that this one goes for hazards. And then we have one that looks at MSD problems and more ergonomics. Then there's a stress assess one, which looks more at the mental health aspects and the psychosocial risk factors at work. Okay, and then it leads you to our website, and this was done in collaboration with the CCOHS, and gives you a lot more knowledge, more information if you want within each of those apps for the knowledge activists that are thirsty for more information. Okay, and that's everything. If you have any questions, I'm sure there's some in the chat, but if you don't have them answered, you can always email me or call me at OHCOW. Thanks.
Thank you so much, Daryl. There's lots of kudos in the chat window about a great presentation, and you know, we've all, I'm sure, had people experience this, and your knowledge is so wide. It's very appreciated. There is one talking about, she had to take a brief call. So it's Erin talking about supporting injured workers and their WSIB claims. So typically WSIB cuts off benefits prematurely and blames the post-concussion syndrome on other non-occupational issues. So whether there was pre-existing conditions, sorry, something just came up on my window. Cuts off benefits prematurely or blames on non-occupational issues, whether they're pre-existing or not. And basically, she's looking to see if the dismissal of the post-concussion syndrome as non-compensable because the persistent symptoms are subjective in nature. Would you have any recommendations for workers on how they might be able to obtain objective medical information to support the diagnosis and work relatedness of post-concussion syndrome? That's a tough one, I know.
Yeah, it is tough. And I actually had a friend who recently went through this. He was a pilot, and one of an object from the plane fell out and hit him on the head, knocked him out completely. And what I was talking to him a lot about was keep going to your doctor and getting it documented. Everything that you do, coming from you yourself, like you said, it's subjective, it's hard to prove. So going to your doctor, and if they can do tests, I know there's physiotherapists that are also certified now, probably other professions as well, but going to one of those professions and having them document it, I think is the help. But I don't know in the end how to get over the subjective, and that is the problem, that is the big problem with concussions and why they can do that.
Thanks. And yes, we will be, the good news is this is being recorded. We will be providing the slides, so no worries for those that are looking for the reference. There is one other question, Laura, if you'll allow me, and then we can move on. So often one gets a suspected concussion. Often when one gets a suspected concussion at my workplace, they're told to go home, not drive, but be driven by another or take public transit. This doesn't sound like the best idea to start with when trying to diagnose a concussion. What recommendation should be the first step?
Well, definitely creating a report, but in terms of what to do with the actual person, seeking the health professional as soon as possible and having them diagnose. I agree. I wouldn't just say, oh, your brain's injured, go home, because of those, delayed symptoms that can come up. They might go home and pass out and have further problems, right? So yeah, I would suggest making sure that they're either getting to a health professional as soon as possible, or that if they are going home, that somebody is with them the whole time and helping them until they can see a health professional. So don't leave them alone is the key point.
Great, and I'll squeeze in one more because I think I can. And any research around pregnancy or and concussions, like related evidence out there on whether they're more challenging for recovery at all that you're aware of?
No, that's a really interesting question. My wife's 7 months pregnant right now, so I'm thinking of what complications she might. Yeah, I haven't seen anything on that, but that's an interesting one.
Great. So yeah, Daryl, I think we covered most of the questions in the chat. And again, hang on, Daryl has provided his email address. We've provided links, thanks to Cheryl and myself in the chat window, to the apps, the Hazard Assess app. Thanks so much for joining us today at this Spring into Action. You are very appreciated. We're happy you came all this distance from the from the Hamilton Clinic.
Yeah.
So,
Okay, thank you so
Thank
much, Daryl. It was really great information. And Kimberly for assisting. If you have any further questions for Daryl, as Kimberly said, it'll be in the chat if you want to contact him directly. Our next speaker is Trevor Shell. Trevor is an ergonomist with OHCOW, and he's graduated from the University of Guelph in 1994 with an honors Bachelor of Science degree in Human Kinetics with specialization in the field of biomechanics and ergonomics. In 1997, Trevor graduated from the University of Massachusetts Lowell with a master's degree in the field of ergonomics and a minor in epidemiology. Trevor is also recognized as a Canadian Certified Professional Ergonomist, a CCPE, and a full member of the Association of Canadian Ergonomists, an ACE. Trevor has been an ergonomist with OHCOW for over 20 years, working with the Joint Health and Safety Committees on a variety of ergonomic issues over a wide range of industries, determining the work relatedness of, musculoskeletal injuries, graphic design, research, and strategic analysis. He's also the coordinator of the annual International RSI Day webinar series. Trevor has also presented at numerous conferences, testified before a U.S. Senate Commission on the need for ergonomic regulations, and has been featured in interviews with CNN, Associated Press, CTV, and CBC Radio. So I'd like to welcome Trevor. And on a personal note, before I retired from the Canadian Association of University Teachers, I worked with Trevor on some ergonomic fact sheets, and he did an amazing job. So if you're ever interested, if OHCOW is able to assist with those kinds of things, you should contact them and see if that's available. Trevor?
Great, thank you, Laura. Can you see my screen okay?
Yes.
Perfect. Okay, well, good morning, everyone. So I've been asked to speak today about shoulder injuries. So we're going to go through the anatomy of the shoulder, common risk factors for injury, look at some of the more common disorders such as rotator cuff tears, osteoarthritis, and thoracic outlet syndrome, and then expand upon prevention measures. Now, the most interesting thing about the shoulder is one of the most flexible joints in the human body that allows rotation in 3 planes. This includes both flexion as well as extension of the arm, abduction, moving the arm away from the body at the side, to adduction, moving the arm towards the body from the side, as well as internal rotation and external rotation. It is this mobility of the shoulder that contributes to the fact of the high incidence of injuries and degeneration about the joint. Now we're going to go through a bit of the anatomy before we actually get into what these disorders are. So this is basically your shoulder joint, and it's comprised of the scapula, or the shoulder bone, the clavicle, or your collarbone, the Chromio-clavicular ligament, the subacromial bursa, as well as the other 5 bursa that do comprise the shoulder, supraspinatus muscle, the acromion itself, the biceps brachii muscle, a shoulder joint capsule, which covers the head of the humerus, the glenoid cavity, which is the socket of the ball and socket joint that makes up the shoulder. From the rear, the scapula again, the infraspinatus muscle, supraspinatus muscle, teres major muscle. And then the other interesting thing to know is, besides the muscles, is we also have nerve supply. So basically from C5 down to T1, which are the names of the vertebrae of the cervical and thoracic spine, we have a number of nerves that come off the spinal cord and feed into the shoulder that then merge together and travel further down the arm. And this is just from the back view. Now, we're also within the shoulder, we have veins, arteries, and just a side view of the nerves and the artery and vein feeding into the shoulder. So that was our anatomy. Just very quickly through it. It's just I will be making reference to anatomical structures as I talk. Now, what are some of the risk factors for injury? Well, the first one is an acute or chronic. So an acute injury occurs as a result of trauma, a slip, fall, impact, catching a falling object. And it's fairly easy to prove that this happened. Whereas a chronic injury occurs over time, years, due to exposures to risk factors and also having a previous injury. These are often more complicated and the reason that claims will often get denied by Wsib. So for previous injury, once a muscle or tendon or even a bone has been damaged, you'll never return back to 100%. So once you've had an injury, you're never going to be normal again. There's always going to be some effect. And one of the reasons for respect to muscle is that you get the development of scar tissue. This results in a loss of function of the muscle. They adhere to the muscle fibers and tendons and prevent them from sliding back and forth properly. They limit the flexibility of a muscle or joint, so there's less range of motion, and can also result in pain. Scar tissue is also weaker, less elastic, and more prone to further re-injury than normal healthy tissue. Another risk factor is awkward postures. So when I gave those examples of the rotation and the flexion, extension, abduction of the arm, those awkward postures, basically for workers that can spend more than 10% of their time in a non-neutral position, are at an increased risk of developing musculoskeletal disorders. This includes working with the arms away from the body more than 60 degrees, such as overhead, abduction, adduction, flexion, or extension. Now, static postures. When we work with our arms extended for a period of time in a static posture, so the arm's not moving. So for example, let's say I'm reaching up overhead. Well, by doing that, reaching up, it places pressure on the nerves and blood vessels within the shoulder joint. So remember, all those nerves and blood vessels I showed it when we went through the anatomy. So this pressure reduces the blood flow to the tissues. affects synovial fluid circulation, results in reduced penetration of cartilage by solutes, and has a reduced clearance of waste products from the joint. So if you've ever done work where you are working up overhead, you'll find your arms, your shoulders, everything gets really sore. You may start getting a numbness and tingling in your hands. Well, that's because of this reduction of blood flow. Blood brings oxygen into the muscles and takes away waste products. When we limit that, we get the buildup of lactic acid. So the muscles fatigue, they get tired more quickly. And it's when we start pushing past that fatigue that the risk of injury begins to happen. So by maintaining that neutral position, you'll always hear ergonomists say, work in a neutral posture. One of the reasons for that, it's like that middle picture that shows the dynamic effort, where we're getting the blood flow we need, and we're able to get everything circulated out. Now, duration, you may have heard this before, as I've referred to in the past as repetition or repetitive motions. As repetition or repetitive motions are a term I tend not to use anymore, because it's becoming more of a time to perform a task or a time that you're spent in a certain position. So, for example, working with your arms away from the body or up overhead. And normally, the result of this is an insufficient rest period for the muscles or the joint to recover. So by being in that awkward position, I said we're not getting the blood flow, the injury begins to happen. Whereas if we're able to rest, do a different task, bring our arms down, work below shoulder height, then the blood flow is going to return and the muscle is going to have that chance to recover. Force. Now there's two types of force. The one everyone thinks of is what they're actually lifting. So, I lift a 50-pound box. However, there's something else, the internal force. How hard the muscle works to move or hold an external weight. The internal force is basically ignored by Wsib since it's not easily measured and requires an understanding and education of biomechanics. Biomechanics is basically physics of the human body. Now, I really want you to get a better understanding of this and just how complicated and important it is to have an idea of external forces. So this is a simplified version. In this example, here in Sudbury, we have a large mining industry, and people will perform what's called a scaling task, where they'll hold a bar up overhead and tap at the rocks to break them off so they're not going to fall on someone's head. The first thing we're going to look at is the force. What is force? It's the mass of the object multiplied by the acceleration, which in this case is gravity. Gravity is pushing down on that scaling bar that the worker is having to work against to hold it up in the air. Force is expressed in units called newtons, and it's basically gravity times the weight. So that's kilograms per meter second squared is equal to 1 Newton. And then there's the torque. This is what's called a moment. So how the muscles have to rotate to stabilize that bar. So simplifying things down, we're able to calculate the weight of the arm. Studies have shown that the arm is about 0.05 times your body weight. And then we multiply that by 10 to get the weight of the arm in newtons. The muscle force, we know the center of gravity of the arm is about 0.467 times the person's arm length. We also know the weight of the bar, how long the bar is, so we're able to calculate the actual force the bar exerts. We know the moment arm of the bar, the person's weight, and that allows us to calculate the weight of the arm and also their arm length. So then we would go through, calculate the torque, so the rotation of the muscles, that the work they're performing to stabilize that bar. And the torque of the muscle is actually equal to the torque of the bar and the arm itself. So we would then plug in these values and find that the rotation about the shoulder muscles is 68 Newton meters. So that means that the muscles of the shoulder must create a torque of 68 Newton meters in the opposite direction of the segment to maintain the bar. We then have to calculate the force of a muscle. So in this situation, when we go through and we plug everything in, we actually find that the muscle, in order to stabilize that bar, remembering that that bar was only 5 pounds, is 68 Newton meters, or 249.6 kilograms. Therefore, just to hold a 5-pound bar, not the action of actually sitting there and actually poking the rocks, moving it back and forth overhead. This is just to hold the bar overhead, results in 249 kilograms of internal muscle force, or 100 times the actual weight of the bar. So this is why knowing internal forces are important, because of the fact this is where the actual injuries are happening internally. Vibration is another risk factor. As the length of time of exposure increases, research has shown about over 9,000 hours. So does even the risk of developing problems like osteoarthritis as a result of vibration. Vibration also contributes to tissue degeneration, especially when combined with sustained static postures. There's a circulatory effect again I mentioned. I did mention that. Vibration also has an effect on blood flow. It will limit blood flow going into the tissues. And some of you may have heard of a disorder called hand-arm vibration syndrome. So what this does is vibration is actually damaging the small blood vessels in the fingertips. So when these factors are combined, they act together to exacerbate the situation and increase the likelihood of tissue degeneration. Vibration will also cause stimulation of bursts of muscle activity that can result in fatigue of the muscles or them feeling tired. So as a result, a worker, when the muscles get tired when using a vibratory tool, they'll actually have to squeeze harder. So they're putting more strain on those muscles. And when you start tensing a muscle, they become rigid, they're less fluid and elastic. So this also increases the risk of transmission of vibration throughout the body. Temperature is another risk factor. Once we start seeing a reduction in blood flow going into the periphery, once temperatures drops, we tend to see the blood stay within the core. And so this limits blood flow going out to the shoulder, which is already an area of very low blood flow. Now, some non-occupational risk factors that can have an effect: age. As we age, both our muscles and joints become less hydrated and elastic. And as a result, it often takes longer to see recovery. Genetics. In some families, there is a greater probability of developing defective connective tissue disorders or a circulatory condition. Infection. Some infections, for example, within the bursar tendon sheath, can give rise to inflammation. Other conditions such as rheumatoid arthritis, gout, lupus, diabetes, and thyroid disease can have an effect. They cause a reduction in blood flow. And once again, the shoulder already has low blood flow. And smoking. Smoking reduces blood flow, and as a result, reduces the healing process. Also, certain types of medications as well can reduce blood flow going into the core of the body too. So one of the first disorders we're going to talk about is osteoarthritis. This occurs when the protective cartilage that cushions the end of the bone wears down over time. Again, remember the shoulder has low blood flow. Risk factors for osteoarthritis include awkward and static postures, because again, limiting blood flow, insufficient recovery time, force, both internal and external, vibration, and temperatures. The primary effect of these risk factors is on the reduction of blood flow. In other words, reducing tissue healing. It commonly occurs in the acromioclavicular joint. So that's where the shoulder bone and the scapula, or the collarbone and the scapula meet, or the glenohumeral joint, the socket of the shoulder. When the stability of the joint is compromised, tiny micro tears occur, including the creation of osteophytes in the joint, thus starting the process of degeneration and osteoarthritis. Now, one study by Elsner in 1995 proposed a mechanism of how osteoarthritis of the shoulder is actually created. So the first is manual labor that includes inadequate recovery times, repeated minor trauma, extreme working postures, in combination with hand-on vibration, the need for stabilization, strong grip, press forces, as well as that reduction of blood flow, which is going to affect dynamic and static joint loading. And then we also have the effect of low frequency percussion vibration, and also individual susceptibilities, genetics, medications, underlying medical conditions, and they all act together to actually contribute to the risk of developing osteoarthritis. Now, for the chromioclavicular joint, cartilage loss occurs between and around the acromion, the scapula, and the clavicle itself. The glenohumeral joint, the cartilage loss occurs within the glenoid cavity, and then you've got the head of the humerus pressing against that. Now, rotator cuff tears, but the rotator cuff muscles connect the humerus, the upper arm bone, to the scapula, the shoulder blade. The rotator cuff itself is formed by the tendons of four muscles: the supraspinatus, infraspinatus, teres minor, and subscapularis, which attach the muscles to the bone. The muscles move the bone by pulling on the tendons, and in this case, can raise and rotate the arm. These tendons run beneath the bony acromion or point of the shoulder. And the rotator cuff keeps the humerus tightly in the glenoid socket of the shoulder blade. Now, these tendons have a very low blood supply, so they're not able to repair and maintain themselves as quickly as other parts of the body. They're especially vulnerable to degeneration from aging due to the fact that, once again, that loss of water, and so they're less elastic. Degeneration is accelerated by repeating the same type of shoulder motions. It's also estimated that up to 40% of the population may have a mild rotator cuff tear without even knowing it. 20% of 60-year-olds have been reported, and 50% of people over the age of 80 will actually have a tear with no idea they actually have one. There's two mechanisms of injury for tears: a trauma, so slip, fall, car accident, sports injury, or chronic use. Over time, tendons wear thin, a tear can develop, often preceded by complaints of shoulder bursitis. And with movements, the tendons can also become impinged under the bones. Now, the development of a tear is a multi-stage process. This first stage normally includes swelling and a hemorrhage, and occurs mostly in young people less than 25 years old after overuse, and it's reversible with conservative treatment. Stage 2 involves fibrosis and tendonitis, and is typically seen in people between 25 and 40 years of age. It may not respond to non-operative measures. Stage 3 refers to bony changes, spurs, osteophytes, and complete tears of the rotator cuff and or the long head of the biceps tendon. Work-related causes: shoulder motions of the abduction and flexion above chest height, internal rotation of the shoulder, protraction of the shoulder, prolonged work above shoulder height, significant durations or heavy forceful motions involving a combination of abduction, flexion, and internal rotation, which can lead to impingement, static tension or positions involving prolonged abduction, prolonged vibration exposure from heavy handheld vibratory tools, and previous shoulder injury. Non-occupational causes: a non-work-related trauma, so an accident, sports injury. Aging, again, the rotator cuff pathophysiology and degeneration has an absolute association with aging, such as developing a partial tear. Anatomical variations, such as a hooked or curved acromion, or other anomalies within the AC joint. Post-operative or post-traumatic scarring, glenohumeral instability, and smoking. Now, there's actually 8 different types of tears, and I'm not going to go into all 8 of them, but the 2 main ones is a partial tear, which goes only part of the way through the tendon. It's usually described in terms of how deep the tear is in the tendon and doesn't refer to the length or width or other dimensions. A full thickness tear is when the wear in the tendon goes all the way through. So remember I said if 20% of the population in the age range of 50 to 60 have a tear, progressing to 50% by age 80, how come they don't know it? How come there's no pain? Well, the rotator cuff itself works like a suspension bridge cable that connects one side of a bridge to another and carries a load from one pillar to the other across a span. So if a tear of the supraspinatus muscle, the top of the bridge, and if the anterior and posterior rotator cuff, for example, the two suspension towers of the bridge, are intact and functioning well, the shoulder function will be maintained because it's making up for that loss. Now, there's different ways to picture the rotator cuff. And I just want to mention that rotator cuff tears would account for the majority of work-related compensation claims I'm personally seeing. I would say about 70% right now of the claims I work on are actually related to the rotator cuff. So one way to think about the rotator cuff is like a pair of jeans covering a bent knee. So in this example, the knee would represent your shoulder. The jeans are the rotator cuff tendons, and the ground are the bones that the muscles rub against with the arms overhead. But have you ever noticed one day your jeans are fine, and then the next day there's a slight hole? Then you may have a minor fall or simply kneel, and the jeans suddenly tear. Over time, the jeans wear out, and if you wear them long enough, they can get radiant spots, and eventually a hole may form. And this is very similar to how a rotator cuff tear develops. So until around age 40, the rotator cuff looks like a new pair of jeans. Around age 45 to 65, the cuff begins to develop tears that will progress in size. And over the age of 65, the rotator cuff becomes even more worn and tears can begin. Now, there also is a link between rotator cuff tears and osteoarthritis. With osteoarthritis, the bones are no longer smooth. They become rough and jagged. So as the tendons are gliding over the bones of the shoulder, rubbing against the roughened surfaces, they produce micro tears, especially with overhead tasks, abduction, and reaching in front or to the side. Now, a way to think about this is a fraying rope example. So any of you that have watched movies where there's someone climbing a mountain, you have the rope running back and forth, and it begins to fray, get thinner. And the same is sort of what's happening within the rotator cuff tear with osteoarthritis. The rock is the roughened bone. The rope is representing our tendon. And that's as moving back and forth, those micro tears begin to happen. This one. Bursitis is an inflammation of the bursa, which is a sac of fluid that cushions the structures of the shoulder as they move to create a smooth, almost frictionless functional gliding, making normal movement painless. With overuse, trauma, as well as various medical conditions, can cause the bursa to fill up with too much fluid, which leads to its filling and squeezing the joint space. Now, just something you should know is that, this came from a claim I'm working on right now, where a worker had multiple diagnoses of the shoulder. He had tendonitis, tendonocytovitis, bursitis, and a rotator cuff tear. These aren't actually different conditions. This is actually a progression of injury. So at stage 1, we've got a normal shoulder. Stage 2, we can get a tendonitis or an inflammation of the tendon resulting from forceful actions or prolonged overhead work. This in turn causes tendonocytovitis. Tendonocytovitis is an inflammation of the synovial sheath, which is done as a protective measure to protect the actual muscle tendon as a result of the tendonitis. With the tendonocytovitis, because the fact it's secreting this internal fluid called synovium, it begins to swell. And as it's swelling, it can result in putting pressure on the bursa, which leads to pushing the bursa up against the acromion and start developing bursitis. Now, the tendonitis, tendonocytovitis, and bursitis can also worsen if osteoarthritis is present in the shoulder due to the rubbing against a rough surface. And progressive micro tears to the muscle tendons can also start resulting, leading to a rotator cuff tear. So these are not happening independently. It's actually almost a progressive stage of degeneration that we start seeing within one's shoulder joint. Another disorder is a thoracic outlet syndrome. It's a disorder that results in compression of one or more neurovascular structures, which are nerves or blood vessels, that travel through the passageway of the shoulder. Compression of the nerves and blood vessels within the thoracic outlet can interrupt nerve signaling, while compression of the blood vessels can impact blood flow. Commonly results from chronic or prolonged movements with the arms elevated or overhead, and from awkward static postures of the head, neck, and shoulder girdle. There's 3 types of thoracic outlet syndrome: neurogenic, which accounts for 80%, venous, which accounts for 20%, and arterial, which accounts for less than 1%. For venous TOS, is located in an area of the shoulder called the costo-clavicular space. It's often caused by elevated or overhead arm use, and the health effect is reduced circulation as well as oxygen nutrient deprivation. Arterial TOS occurs in the interscaling triangle. It's often caused by structural abnormalities. So some people will actually be born with an extra rib up in their collarbone area. And so this can result in arterial TOS. And the health effects tend to be ischemia and embolism. Neurogenic TOS is the one we commonly think of when looking at thoracic outlet syndrome and work-relatedness. It accounts for 80% of all cases and can occur in any of the 3 spaces within the shoulder. The causes vary. The health effect is pain, numbness, tingling, and a cold sensation. So the causes, well, one can be trauma, an acute injury, bone fracture, whiplash can all have an effect on the thoracic outlet syndrome or outlet. I mentioned structural abnormalities, so an extra rib, an elongated C7 transverse process, narrow interscaling triangle due to shorter muscles, reduced passage through the space, fibrous bands or extra ligaments. Work-related causes, the first being awkward, static, prolonged postures. So these can have an effect on the muscle length, as well as compression of the brachial plexus, result in muscle weakness, and as a result in muscle overuse. So with overhead work, here's an example of someone working with their arms up overhead. This can actually cause, once you bring your arm up, you can see how the structures of the shoulder are actually being compressed with overhead work.
Trevor, it's
Yes,
Laura. Just reminding you, you have 10 minutes, including time for questions.
Okay, thank you. Just an aside, the venous TOS can be affected very similarly. Other work-related factors, external forces, compression, such as carrying heavy loads, carrying things on the shoulder, or even carrying a bag on the shoulder. The symptoms can range from the shoulder to the forearm and the hand. Because these nerves are coming off at different points, the nerves themselves can be compressed at any of the 3 locations within the spaces. And of course, different nerves can be impinged. So it all depends where along the brachial plexus the impingement is occurring within those three spaces. That will determine which nerves get affected. Most commonly, though, is that neurogenic can also mimic the results of carpal tunnel syndrome, because the nerves that are being compressed can form into the median nerve. Carpal tunnel syndrome is impingement of the median nerve itself. So often you'll see the exact same symptoms happening with carpal tunnel syndrome and TOS. So to prevent it, you want to minimize awkward postures, keep the arms below 60 degrees elevation, minimize the time spent in awkward positions, minimize reaching, try and get as close as you can, monitor the number of tasks that require overhead work, change the tools or equipment. Now use bit extensions for drills and screw guns that allow you to hold the tool at waist or shoulder level rather than over your head. See if you can find tools that weigh less. Use a step stool, ladder, mechanical lift, hoist. Some people even use stilts to raise and position yourself closer to the work so you're not reaching overhead. Use a tool balancer. This will actually act to support the weight of the tool, so you're not actually physically lifting it. The balancer is taking on the weight of the load, and you're simply guiding it while you're doing your job. Listen to your body. If your shoulders get sore after any activity, don't ignore it. Take a break for a couple of minutes every hour, move around, get the circulation going, do some stretching. Avoid sleeping on your side with your arms stretched overhead. Try not to lie on your shoulders when you sleep. If you smoke, try and quit smoking. It does decrease blood flow going into the shoulder. CRE-MSD has developed some great infographics. Unfortunately, actually, when we can also send out a PDF of these slides, so you'll actually be able to click on the link. But you can also just find it by Googling CRE-MSD overhead work, and it will take you directly to their infographic on preventing shoulder injuries. They also have a YouTube channel with a video that shows this digitally as well. So you want to try and once again minimize high precision tasks, minimize the direction of force, and again reduce the amount of time spent overhead. They also give some suggestions for reducing overhead hazards. Keep your arms below 60 degrees. Whenever possible, adjust the tool or workspace to decrease the time spent overhead. Perform work close to the body. Ensure your arm is free to rotate. Ensure tasks that are completed overhead have a low precision requirements. Keep overhead applied forces in the vertical plane. Use lightweight tools. And introduce rest to give your body a chance to recover. And that's it, Laura. So I think I finished on time.
That's great. Thank you so much, Trevor. So we have 5 minutes for questions. You can either unmute yourself and ask. I know that our Cheryl and Jen are watching for hands that are up if anybody wants to put anything through the chat as well. I'm looking to see if there's any hands up. Okay. So I don't see any questions, Trevor, but I just do again want to say what wonderful expertise we have amongst our OHCOW staff, and they're available when needed. They'll provide whatever assistance that they can for whatever the reason is, and so please make sure that if you have questions or you have injured workers or you want to do prevention, because of course prevention is key. We want to prevent these things from happening to begin with, that you inquire at OHCOW to see what might be available for you for this assistance. I'm just looking to see if there's any questions. Is there service in which someone from OHCOW can do an ergonomic assessment in the workplace? Trevor?
We can definitely help do workplace assessments and give recommendations to reduce these risk factors. Definitely, that is part of our core service. As David mentioned at the start, our services are free of charge. And so as a result, we're a free service that we do work with the Joint Health and Safety Committee to determine the risks of injuries and provide recommendations at no charge.
Great. We also have, thanks from Joe from Texas. That's wonderful. We have somebody here from Texas. We do have another question. Can anemia reduce blood flow?
I'm not really sure. I'm not that familiar with anemia itself and the effect that it does have on the body. So I really can't answer that one.
Yeah, it's always interesting when we do presentations. We get new and interesting questions about things we might not have thought about before. So one person here has at their workplace have a history of shoulder injuries, packing, crating, often with diagnosed chronic with over repeat use of work. Often WSIB does not want to continue with the claims. With new information science, do you see this changing at all with the knowledge finally happening?
I can't comment on WSIB's practices, why they would not want to continue with the claim. I said the other, it's hard to even get people to understand that, as I mentioned, a lot of these injuries aren't separate conditions. It's a progression or a worsening. So when we're talking chronic, I mean, as I said, we can start with a tendonitis, go to a tendonocytovitis, to a bursitis, to a rotator cuff tear. It's all part of a continuum that people need to become more aware of as well. I've often seen other places use different terms interchangeably. For example, hand-arm vibration syndrome and Raynaud's are often used by WSIB as the exact same condition, but they're not. Raynaud's is a genetic condition, whereas hand-arm vibration syndrome is actually caused by vibration. So best thing we can do is keep trying to educate and get things out there so people actually get a better understanding that things are the way they are.
And I think that's the key piece is this is really helpful education for our Joint Health and Safety Committee members, our unions, and our workers to understand that and how they can better support their workers. One last question. Somebody has had surgery due to a rotational cuff tear, and it's been 6 months, and with physio, the recovery is not complete. Is this normal?
Once again, it depends on the age of the individual. As I mentioned, as we get older, it does take longer to recover and heal, especially within the shoulder because there is such low blood flow. It also depends on whether it was a partial or a full thickness tear, what was actually done. And as I said, once we do get injured, we're never going to return back to normal 100% again. So I would give it a bit more time. I mean, the shoulder is just such an area that's used so much that I would actually just give it a bit more time. Talk to your doctor. That's your best resource. Just talk to your doctor, your physio, ask what the standard healing from surgery is.
Thank you, Trevor. So I'm going to take a question or comment from Kimberly, and then we will be taking a break, but I just want to remind people to fill out their evaluation form at the end and our game to win the book. And please be back promptly at 11 o'clock. Kimberly?
Thanks. Just to add to one of the questions about the ergonomic assessment. So the majority of OHCOW's work is to determine with an interdisciplinary team, if an injury that's been that someone had, or an illness, occupational illness is and also injury, as you've heard from our ergonomists today. So we have occupational health nurses, the client service coordinators, ergonomists, hygienists, and physicians all working together to see whether illness or injury was related to a workplace exposure. So that's the majority of our work. out of that, we've tried to create prevention tools to help with our free services. So we're not competing with, we can't send people everywhere to do ergo assessments. There's no way we have enough resources for that. But we'll refer you to private consultants. A couple of them are on the call today. Work with them. We'll work with your Joint Health and Safety Committee. We want to empower workers, provide knowledge translation. We have tools, ergo calculators that have the, but no, we're not going into every workplace and doing individual workplaces, ergo assessment. So I just did want to clarify that, that we'll hook you up and empower and work with Joint Health and Safety Committees. And we want to take all the lessons from our determination of work-related illness and injury and help prevent. I just thought I'd clarify. Thanks.
Thanks, Kimberly. Okay, so we are going to take a break right now. If you have any more questions for Trevor, if a link could be put for Trevor into the chat, people could contact him directly. Please be back at 11 o'clock sharp. Thank you. Okay. Okay, thank you, and welcome back, everyone, for our last session of the morning, our new guest speakers, and I hope that this will round out a really great spring into action for our LAC. So we have with us today James Brophy and Margaret Keith, who both have PhDs in environmental health from the University of Stirling in Scotland. As a couple and as research partners, they have studied an extensive range of important occupational environmental health issues. Both worked at the Sarnia Occupational Health Clinic for Ontario workers, excuse me, where they helped to document one of the largest cohorts of asbestos diseased workers in Canadian history, the industrial workers in Sarnia. They also assisted the First Nations community of Amjimwanaag in examining health problems that were hypothesized to be associated with environmental pollution arising from the petrochemical industry. Margaret was a co-author, along with Ada Lockridge, of an article that found a skewed birth rate amongst that community that generated international scientific attention. In 2008, they were recipients of the Gold Award in Environmental Health by Canadian Geographic for their work in assisting with the Amjimwanaag community. They have published numerous articles in peer-reviewed scientific journals and contributed several book chapters to academic publications. Together, they were awarded the Scientific Award for the Occupational Health section of the American Public Health Association for the rigor displayed in their groundbreaking occupational breast cancer research. Together with Michael Hurley, president of the Ontario Council of Hospital Unions CUPE, they have just had a book published entitled Code White, Sounding the Alarm on Violence Against Healthcare Workers, which drew heavily on 3 important research studies they conducted over the past 5 years. The first 2 focused on violence against healthcare staff in the hospital and long-term care settings, and the third on healthcare worker protection during the pandemic. So over the next hour, Jim and Margaret will talk about their work, their study, their experiences, and they'll have ample time for you to ask questions and engage on this very, very important issue. Jim and Margaret.
Thank you, Laura, and thank OHCOW Ottawa for inviting us to speak today about what we will be arguing is an epidemic of violence in our healthcare system. And I also want to thank all of those that are participating today. I particularly have in mind those that may be healthcare workers and other public sector workers that confront the risk of violence on a daily basis. And it's for you and your experience, stories, and point of view that this work has been done. So thank you very much for participating. Over the past 5 years, we have found ourselves immersed in a subject we were completely in the dark about, until we began a series of research studies to explore the serious issue of violence against nurses and other healthcare workers. We have come to believe that it is a human rights and social justice issue, and one that is widely hidden from the public view. This book, which we wrote and was published this past September by Between the Lines, and will be released as an audio book at the end of the month, was done to amplify the voices of healthcare workers who are eager to safely share their experiences. An important takeaway that we are going to discuss is we believe the well-being of healthcare workers is a useful barometer for the health of the healthcare system, both of which are in crisis.
The peer-reviewed journal articles and this book that emerged from our research tell a story that must be told. We would go so far as to say they reveal secrets that the healthcare industry and government regulators seem not to want the public to be aware of. It wasn't until we began to explore this issue that we ourselves really had any idea of the seriousness or the widespread nature of the physical, verbal, and sexual violence that healthcare staff are facing on the job, many on a daily basis. I'm going to give you a little bit of a sense of what we heard. These are a few incidents that we heard about when we were talking to people. One nurse told us, on a daily basis, I am hit, punched, spat at, sworn at, slapped, bitten. I've had hot coffee thrown at me. I've gone home with burns on my hands. Another said, I was just fixing his shoelace and he punched me in the back of the neck. I didn't see it coming. I put his pajamas on and I went to tie them. Then I saw his fist. Oh my God, here it comes. Pow, right in the mouth. It cracked all my teeth and broke my nose. And another one, and these are all the same person, a patient on a medical unit who wasn't getting a cup of tea when he asked for it stabbed me in the arm. I had my ribs broken when I was working in the emergency room of a hospital and was put through the wall because a patient didn't like being told he would not be given the drugs he asked for. I've had my leg severely broken. I've also had a chunk of flesh bitten from my body. I've had my head wrung, my jaw twisted around. I've had my family parts assaulted on many occasions. We also heard of many troubling incidents of brutal sexual assault and racially motivated abuse. We had a PSW who was working in long care who talked to us in tears about an incident where she was trapped in a shower room with a very strong resident. He was in his 50s and he had early onset dementia, still relatively mild at that point. And he slammed her against the wall and went about sexually assaulting her. She was screaming for help. Nobody heard her because they didn't have proper systems in place for her to be able to get help. It left her extremely traumatized. And when she tried to go home, she was told by her supervisor that she couldn't because they were too short-staffed. She ended up having to leave anyway. But we were in a group of about 5 or 6 people. They were working in the same facility. They knew each other and everyone was in tears. And then everyone started talking about incidents that they had like that. We've heard of careers ended and lives ruined because of devastating physical injuries and psychological trauma. Some of you may have heard of Diane Paulin. She was working as a psychiatric nurse in North Bay when she was asked to go into a room with a patient who was there because he had such violent tendencies. In fact, he had been working in a group home. He was in the group home because he had assaulted and sexually assaulted his mother. And then he had been, the police had to remove him from the group home. He assaulted them. This man came into the facility and was in terrible shape, finally calmed down enough that he was put into his own room. The person who was tending to him left. Diane went in. Next thing you know, he's raging, slammed her up against the wall, ended up punching her. She ended up losing teeth. She had a serious concussion. She had injuries all over her body because he had slammed a chair up against her. Again, these are all situations that could have been prevented. Knowing he was violent, She could have gone in with another person. The door shouldn't have been able to slam shut against her, or at least, you know, to block other people from coming in. She never was able to return to her job.
Recorded statistics underestimate the reality of violence against healthcare workers, largely because there is widespread underreporting of violent incidents. It was affirmed by the findings of a 2019 Federal Parliamentary Committee report. But looking at the numbers that are available, we see that out of all occupational groups, healthcare workers bear the greatest risk of workplace violence. Between 2006 and 2015, there were over 16,000 violent-related lost time injuries among Canadian healthcare workers, compared to 7,500 among those in non-healthcare occupations combined. In 2017, the Canadian Federation of Nurses Unions reported that 61% of the RNs surveyed experienced serious workplace violence, in contrast to 15% in all other industries. In 2017, the Ontario Council of Hospital Unions, CUPE, commissioned a province-wide poll of its members to investigate the prevalence of violence perpetrated against hospital staff by patients. A total of 1,976 healthcare workers participated. According to the poll, 68% of the nurses and PSWs had experienced at least one incident in the past year of physical violence.
And of course, these numbers represent real people. This is Scott Sharp. This was an article that was done on him in the Toronto Star. We have met him on numerous occasions and have interviewed him. He was a healthcare aide working in a Guelph hospital on a night shift when he was asked to come and help with a patient who was lashing out against the nurse that was tending him. Scott ended up being thrown through a wall, slammed up against a gurney. Anyway, he suffered serious spinal injuries, has had numerous surgeries, has been in rehab, ended up, of course, you know, in a battle against the Wsib, losing his home, losing everything. He was unable to return to that job again. And really his life has been changed forever. He had been a very athletic, very strong man who called himself a jock, played sports with his children. All of that changed in this one episode that once again could have been prevented. As Jim said, we didn't really know how much violence there was out there, or exactly what was going on. We also, before we undertook the research, didn't really realize how seriously our healthcare system has been allowed to erode. In numerous surveys, the majority of healthcare workers say they are simply not able to provide proper care. The epidemic of violence is in many ways an escalation of the ongoing failure of health and safety regulatory oversight. It also underscores the chronic underfunding and increasing privatization of the healthcare sector. These problems are aptly illustrated in Ontario, where bed shortages, wait times, and understaffing plague the system. In 2019, the Canadian Centre for Policy Alternatives reported that Ontario was tied for last place with Mexico, having fewer hospital beds per capita than any of the developed countries they examined. And of course, that means staffed beds.
We undertook our research to understand the causes of violence and what is needed to prevent it. Over a period of 5 years, we spoke with hundreds of nurses, personal support workers, kitchen staff, cleaners, and other allied workers. We learned that healthcare workers are suffering in silence from inadequate protections, overwork, exploitation, burnout, a lack of respect, and from violence perpetrated against them. We learned that remaining silent is not their choice. It is imposed upon them by employers who threaten to discipline or fire them if they publicly speak about their concerns or their suffering.
I think it's really important to note that the vast majority of healthcare workers are women, more than 85%. Many are racialized. Violence against healthcare workers is yet another manifestation of violence against women and racialized individuals. As we say in the book, We all need to be able to talk openly about such issues as violence, fear, discrimination, and burnout. Rebecca Solnit, who has written about the silencing of women as a form of control, says, being unable to tell your story is a living death. Violence against women is often against our voices and our stories. Silence is what allowed predators to rampage through the decades unchecked. Having a voice is crucial. It's not all there is to human rights, but it's central to them. And so you can consider the history of women's rights and the lack of rights as a history of silence and of breaking silence. You may have heard of Sue McIntyre, who was fired from her job as a psychiatric nurse in North Bay because she was quoted in the newspaper as saying violence is an issue that needs to be dealt with. No specifics. She didn't name her employer. She had been to a conference where the issue was being discussed. She was a CUPE member. It took 2 years for her to get her job back. But that incident was something that had a chilling effect when we were recruiting people for the research and when we were talking to people in interviews. All of them mentioned that and said they were so afraid that somehow their identity would be, that someone would find out, that their employer would find out, and they would be fired, like Sue had been. So we were extremely careful about protecting their confidentiality and anonymity. And to add insult to injury, literally, assaulted. Post-incident debriefs often begin with their supervisor asking questions like, how did you approach the patient? What was your tone of voice? This sounds uncomfortably like the way women have been made to feel by society when they've been victimized by violence, an injustice that's now being widely challenged, thank goodness. To add further to the harm that is done by the violence itself, many staff find themselves without adequate post-incident supports, leaving them to suffer emotionally, physically, and financially.
We also learned that the experts, the healthcare workers themselves, have provided a roadmap for regulators and administrators to follow. But they made it clear that there are serious barriers to be overcome before that can happen, such as the normalization of violence, the idea that it is simply part of the job, the systemic underreporting of violent incidents, the lack of respect from patients, residents, and their visitors, and from higher status professionals and supervisors. They also cite poor communication and the threat of reprisal for speaking publicly as obstacles. Two issues stood out for us as the most significant barriers to change. There is a lack of institutional and legislative acknowledgement of the enormity of the problem of violence against healthcare workers. And correspondingly, a lack of resources such as adequate funding, beds, staffing, appropriate facilities, preventative programs, and security measures. Furthermore, the problem has been effectively concealed from public scrutiny. As a result, there is little public pressure to change the conditions that lead to violence.
It was apparent after speaking with hundreds of healthcare workers that many of the risk factors for violence are modifiable. In other words, prevention can be accomplished. Ensuring adequate staffing levels, a strategy recommended in much of the published research literature, was cited and emphasized by healthcare workers in every interview that we did. Engineering controls such as better building design, better communication and identification strategies, increased security, and zero tolerance policies were also recommended. But we've come to understand that prevention efforts need to address not only immediate safety concerns, but also underlying systemic causes such as gender and racial discrimination. While we were in the process of finishing the writing for the book Code White, the COVID pandemic arrived in Ontario, shedding even more light on the working conditions we had been documenting. As we wrote in the preface of the book, we have since learned, not unexpectedly, that the problems we had learned about only became worse when COVID hit. Hospital and long-term care workers had been facing serious challenges before the pandemic. Already overworked, burned out, and demoralized, they now found themselves in the midst of a full-blown occupational health crisis in a system that did not have the resilience or the resources to meet the greatly increased needs of patients, long-term care residents, or the people who care for them.
The pandemic also brought about a further degradation in the working conditions. Increased staff shortages, stress, and patient and resident frustration had led to even greater risk of violence. Violence against healthcare workers, already a serious problem in hospitals and long-term care homes across the province, has been exacerbated by lockdowns, canceled programs, and restriction on visitors.
One of the long-term care residents whose routine was changed because of the pandemic lashed out at one of his caregivers. She told us, "There's always been a lot of violence with residents, especially when they have dementia. They can get very agitated or aggressive." His anger kept building up, and after a few weeks, he was at his max. We had been saying that he's really getting frustrated, and someone needs to come in and figure out something for him. It didn't happen until I got punched in the face, and she was hurt. The fact that healthcare workers have not been given the equipment that they need to protect them from being infected with COVID has also created fear and frustration. Many told us that they had requested N95 respirators, which are specifically designed for airborne protection, but were denied. As we wrote in an article early on in the pandemic, when viewed through the experiences of those on the front lines, the coronavirus response has been a series of failures. Failure to apply the precautionary principle, fundamental to public health, failure to provide proper protections for workers, failure to implement recommendations to improve worker health and safety, and failure to place human health before the economy. The lessons of the past are crucial to understanding what is happening now.
About a week ago, I marked an exam for a part-time student, a university student who is also a full-time nurse. I asked her permission to share of her answers about sacrifice zones, which are areas or communities known to have high incidence of exposure to risk. She wrote, "I strongly feel the healthcare community has become a sacrifice zone where violence towards workers is acceptable. As a nurse, I am subject to physical violence in the workplace from patients who have a right not to be clinically or physically restrained. Verbal abuse from families expressing their frustration over the lack of ease investigating the healthcare system, as well as being excluded from workers' rights, such as the right to refuse unsafe work, as other Canadians are entitled to. And as violence is considered to be part of my job, the past 2 years, it has been become normal for us to go to work with increased anxiety as we account for how short-staffed we are, as we will be the shift. If we will be able to leave after 8 or 12 hours, or if we will be mandated to stay overtime because the new shift is too short, while we are bringing the virus into work or at home to our families from work.
Ontario's healthcare system and public health approaches under neoliberal austerity-driven cuts have dismantled an important part of our social safety net, and COVID has exposed the consequences. The Ontario Health Coalition recently released a statement calling for emergency measures to address the Ontario healthcare crisis. In it, they say inadequate funding and labor force restructuring have resulted in crushing workloads. Insufficient staffing and increasing violence have contributed to untenable rates of injury among healthcare staff. Planned underfunding, budget constraints, and legislated wage suppression turned the shortages into a crisis. In the pandemic, the staffing crisis has become a full-blown emergency, made worse by inadequate personal protective equipment and safety protections for workers. For-profit privatization has exacerbated these deteriorating conditions.
The current healthcare crisis provokes a number of questions. What will the world look like after the pandemic? Will we be better prepared for the next one? Will healthcare workers be better protected? Will there be reinvestment to remedy the weakened public healthcare system? Will we have the moral decency to give the affirmed, and the elderly the compassion and care they deserve? Are there lessons for broader precautionary measures and other crucial health threats, critical health threats, such as climate change? We clearly need a systems approach that sees beyond the individual to the collective nature of how we live, work, and play. A revamping of priorities away from the profit motive and towards the health and well-being of persons mandates the investment in preparations that would mitigate risk and improve the lives of everyone.
We know that Code White is an uncomfortable book to read, but we believe it's an eye-opener that might just inspire its readers to start crying foul. The bottom line is that healthcare workers are being exploited. Those of you who may be healthcare workers on this call, don't have to be living and working in pain and fear. Violence can be prevented. COVID transmission to healthcare workers can be prevented. Failing to protect them is a form of violence in itself. As we wrote in Code White, it is our fervent hope that this book opens the doors of our healthcare institutions wide enough that we can hear the voices, the pleas of those who care for us when we are sick and weak and unable to look after ourselves. We can't ignore this issue any longer, just as we can't ignore domestic assault, discrimination, harassment, or sexual assault. Violence against healthcare staff is a human rights issue that we are all being challenged now to address. Thank you. So we can take questions if anyone has any questions.
Thank you very much, Jim and Margaret. That truly is. It's not shocking to me. I was a nurse for 30 years back in the 70s, 80s, and early 2000s. Those are very familiar personal stories to me, including the normalization of that violence as an expectation as part of the job. So we do have some comments here in the chat. One of them is, how would they be, how can we order your book? So if we can get that before we leave. Another comment is from regarding WSIB claims. She's had multiple, workers had multiple injuries in the workplace at the hands of residents, and then of course developmental health injuries on top of that. And the case manager from WSIB said being beaten up by residents would be considered part of her regular job duties. So this is exactly going to the heart of what you were trying to get at, that the system okays it. And so that's truly problematic. Do we have any other questions? If people would like to unmute themselves or put their hands up. I know that some people are here representing their unions, and they may have healthcare workers amongst those members. But even if you don't, it's a revelation to really clearly understand about what's happening in our healthcare system. Do you have any resources related to Code White debriefing strategies and tools for healthcare settings? This would be a great tool if you have some ideas.
Well, I'll go back to the idea first, just to mention how to get the book. The book is at Indigo. It's in Amazon. It can be ordered directly from Between the Lines. And at the end of the month, the book is going to be released as an audio book. And I think we're very pleased about that, because we think that's probably in a format that's much more accessible to healthcare workers. So the Code White issue, well, I mean, let me just preface by saying that, you know, the healthcare workers bore one of the highest rates of infection of almost any occupational group. But even in the general population, I mean, through the first year of the pandemic, I think close to 20% of the cases were among healthcare workers. And we did do a study early on in the first months of the pandemic. And even then, there was tremendous frustration among healthcare workers that they were not being given adequate protections. All the recommendations of the SARS Commission from 2006 had been completely ignored. So the major recommendations about healthcare, everything from N95s to following the precautionary principle to creating a culture of safety and health in the hospital sector, the special role of the employers and of the government listening and engaging with both healthcare workers and their unions, all of those things were completely set aside. And of course, there was systemic blocking of workers even exercising their limited rights to refuse unsafe work. The Toronto Star did a major article using the Freedom of Information to show how that was denied. So I don't know of the particular, any of the unions, the particular educational materials, or whether OHCOW or others have prepared that kind of documentation. Certainly, minimally, they need N95 respirators. The ventilation systems in the hospitals really need to be checked. All the safety procedures that would limit transmission need to be employed. And they need to activate their occupational health and safety committees. That was one of our experiences through the research, that the occupational health, the joint committees had pretty much collapsed. And I'm talking now in 2017, 18, and 19. And through the pandemic, that was a similar thing reported by the unions.
I want to address a couple of the questions too. This idea about violence being part of the job. And we did talk to healthcare workers who had received in writing, rejection of compensation claims, because it said right in it, this is, part of the job. It's to be expected. It is not part of the job. It should never be considered part of the job. We know that it can be prevented. There are examples. We know in Scandinavia, for instance, looking in the long-term care facilities, there's 6 times fewer incidents of violence in Scandinavia because they are addressing this problem. We are not. We're ignoring it. People are not allowed to talk about it. Thank goodness the unions are now speaking out more, I think, in the last 2-3 years than they ever have. I think they're, starting to recognize that this is a human rights issue. I think the Me Too movement has helped to a certain extent. There is a cure. We have looked at this whole issue in detail. We know what's wrong and we know how to fix it. And really, so do the regulators. It's a matter, though, of getting the resources put in place. In terms of, I think one of the questions was about strategies around debriefing. One of the recommendations that came out of our many discussions with healthcare workers is that the people doing the debriefing need sensitivity training. They need to understand what it is that the healthcare worker has just experienced, not to automatically go to blaming the healthcare worker for something that they have done, for their approach or their tone of voice, or flicking the light on too quickly, or whatever it might be. Of course, all those things are important. It is important for healthcare workers to understand how to approach a patient who's potentially violent, how to de-escalate, and so on. We should be able to prevent violence from happening. But if it does happen, let's not cause further harm by then putting the healthcare worker through a grilling and blaming them essentially for what has happened to them. They need support. And so beyond the recommendation that management go through sensitivity training, and they need to understand the way someone at a sexual assault center has been trained to deal with people who come in. And let's be honest, a lot of these healthcare workers have been sexually assaulted or sexually harassed, and certainly physically assaulted. There is a way that you support people who have gone through that, and a lot of, and some of the supervisors, I should say, I mean, we were told that there are some very good ones, very sensitive ones, who are seen as co-workers, but there are others who just don't seem to get it. So I think that's an important thing to pursue.
So we do have a comment from an educational assistant experiencing this similar things from students, and we know that is also rampant in the educational sector. But just to tag back on to the WSIB, there was a secondary comment that a lot of healthcare workers are part-time and casual, so they don't have access to LTD. And then compounded with the WSIB expertise in denying claims. Unfortunately, many of these workers end up living in poverty. Exploitation is what you were saying. And of course, you know, back in the 70s and 80s, when I first started working, the majority of jobs were full-time jobs wherever they were. The majority of jobs now seem to be part-time. And so that's also another crucial component. Kimberly,
Laura, just to pick up on your point on the WSIB, I would say the frustration that we heard from the healthcare workers toward the conditions of their work, toward their employers and the way they were treated was second. I mean, it was hard to say who they were more upset with. Was it the employers or the WSIB? Because the experience, the overwhelming experience of the healthcare workers is, as Margaret was describing, not only are they blamed by their employer after an assault or after a violent incident, and often unsupported, and they don't receive the kind of psychological assistance that they need, but the WSIB re-triggers the whole process.
Yeah.
I mean, the two pictures that Marg put up of Diane Paulin and Scott Sharp, both of them suffered enormously, lost their homes, all in disputes with the WSIB. And so the anger that healthcare workers and the frustrations that they have toward a system that does not only doesn't give them justice, but also re-traumatizes them is enormous.
And the issue of pre-existing conditions, Diane went through a psychological evaluation and, you know, was asked all kinds of questions and revealed that she had been traumatized as a very young child. And they decided to use that against her and say that the reason she was suffering such post-traumatic stress disorder after this vicious attack was because of this early childhood experience, even though she had nursed as a psychiatric nurse for, you know, 20 odd years without any problems. It was after this vicious attack that
pre-existing condition.
Still, I mean, she still is physically from it, not only emotionally, but they originally denied her claim based on that. She did, when they sent her to various jobs that were completely inappropriate for her, that were very stressful. They just, you know, that lack of sensitivity was just stunning.
Yeah. Kimberly, if you want to expand on your question, is a potential expansion of the research being considered for educators? You want to expand on that a little bit for clarity?
Well,
Kimberly was going to speak.
Oh, is Kimberly? Yeah. Oh, I'm sorry.
Yeah. Yeah.
Oh, no, it's fine. There's no so someone else was on talking about being an educator, and I was just curious if your good work has been thought to expand to educators as a, yeah.
Okay.
Well, we are very aware, number one, that, you know, closely akin to what's going on to healthcare workers is being replicated in the education sector.
And in fact, the lost time stats from the WSIB have the healthcare workers and education workers
side by side.
Much, yeah, in terms of violence. So yes, they're right up there with healthcare workers.
And secondly, it has been our 40-year experience that work environments in which women predominate or racialized workers predominate, male or female, are areas where regulatory supports are close to non-existent, and the kind of support, their issues get just unaddressed. When we were doing the studies, and these were collaborative studies we did with the Ontario Council of Hospital Unions, CUPE, Mike Hurley, who's the president of OHCOW, was actually speaking with the education workers at CUPE about this, and he spoke with us about, you know, how serious the problem was. And there was some discussion, I don't know exactly what came of it, but that both the education sector and the hospitals and long-term care sector needed to meet together because this was clearly a joint problem. And I think the one last thing to say is, I think that what's going on in the education sector really needs to be brought out to the public. I know that I think it's the Elementary School Teachers Union, they have been speaking out loudly on this issue. But I really think that the public is unaware that the same systemic factors of underfunding, understaffing, the lack of regulatory controls and so on and so forth are plaguing our education system the same way that it is our healthcare system.
And I do think doing formal research does help to get the message out. I think it's why we were asked to do this in the first place. Again, because the healthcare workers were not allowed to speak out about this, we were asked essentially to gather their stories and their voices, and we would tell those stories in order to get the information out. And having gone through all the formal channels, getting the the ethics approval from the universities, and having the articles going through peer review, and making sure that we were following good solid research protocols, I think really helped when we did publish, when we did talk about what we had published. It I think added a certain validity. I mean, we shouldn't have to do that. The workers should be able to talk about this and be believed, but somehow I think having these formal research studies has helped. In fact, QB had us come in when they were in negotiations to present to management the first study we had done on violence against hospital workers. And they felt that it was important that we put forward what our findings were in this formal, validated research. So I think the idea of something similar being done with the education workers is a great idea. We would be happy to share our methods if there's anybody who wants to take it on. But I do think that having these formal studies is helpful.
So I think the last comments that you've just been making are truly important. We've all had those experiences with our employers where they want the proof, they want the studies, they want the name. And for those of you that are attending the conference, for yourselves and to share with others, the work that Jim and Margaret have done is a place where you can go to for validation and to say, see, look, this work has been done, it's out there. And again, you shouldn't have to keep proving things or not being believed. Unfortunately, we still have to have the, as you say, formal investigations and studies behind us before we can get the employer to engage at the table sometimes. I do appreciate your support of the Joint Health and Safety Committees. That is absolutely essential. Jim?
I think we may have sent you copies of our studies. If not, we will. And if anyone wants them, they can certainly contact you about them. And they're,
okay.
Yeah, they would be available.
Okay, I know they went to Aaron, so,
okay.
And I think Aaron might have shared them, but yes, we will do that. Do we have any other questions or comments? And I'm just scanning through to see if I see any hands up. Did you have any last thoughts yourselves before your session closes?
Well, I mean, first of all, thank you for allowing this discussion to happen. I hope we addressed the concerns and so on of the participants. I think that this issue is not resolved. In fact, we know from both studies and from articles in the press that violence has actually increased during the pandemic, that nurses, for instance, and personal support workers are leaving the profession in droves. They're voting with their feet, that there is a very deep crisis emerging inside our healthcare system, of which violence is an expression. So we have major institutional issues facing us. and as well as, the serious issue of working conditions for our healthcare workers and others. So it's not an issue that's fixed or resolved, as much as we would think after all the publicity and so on, that CUPE and other unions, other healthcare unions have done, ONA and the National Canadian Federation of Nurses Unions and so on, and new unions across the country, but it's not. And so we just have to keep digging in and relating this issue to the broader issues of the public, which are really around the state of our healthcare system.
And I'm grateful too. I mean, I think you're helping to break the silence. I think that, that's why we're speaking out the way we are. I think it's important that we also get the public on side, because this very much affects them as well. Healthcare workers who are burned out, injured, frustrated, they can't do their jobs. They're, the understaffing is a huge problem for them. It affects them. It affects their well-being, but also affects their ability to care for patients and for residents. And I think the more we can let the public know about this, the better. We also think it is important for us to be knocking on the doors of the legislators. We were privileged to be able to present to a federal parliamentary committee on our research, and I think that probably helped a bit. There was a bill put forward to criminalize the acts of violence against healthcare workers, to see it as something beyond, it needs to be part of the criminal code. We don't just excuse violence because people are, have mild dementia, or we need to look at each case and see whether or not a person should be charged. And I know that there are pros and cons to all of that. We also need to support the whistleblower protection that's been put forward provincially. Franz Jelinas from Sudbury, I think, has put it forward twice now to make it safe for healthcare workers to speak out about violence without fear of discipline or termination. And so getting behind and supporting the legislation, I think, is important. We have a number of recommendations in the book, support the Ontario Health Coalition and organizations like that. And of course, the unions have been speaking out. As I say, there have been rallies. There have been some excellent campaigns launched in the last couple of years around violence. We need to get behind those unions, and we also need to make sure that our own unions are well aware of what's going on. The healthcare workers need to be sure to talk to their union reps, and the joint health and safety committees need to be able to talk about these things and get them resolved in order to get preventive measures put in place. And we need money pumped into the system so that the healthcare system can be safer for healthcare workers and for patients and residents.
And some of the first steps we can also take is right in our own communities, working with our municipal councillors and governments locally, because that's where these businesses are in our local communities, and with other organizations like our labor councils and other community advocates is a really good place to start. It's not so daunting if you're somebody that's on the front lines to start at a place like that. Thank you so much again, Jim and Margaret, for coming. We hope to have you back again sometime in the future for another event. And we will be just doing some closing remarks shortly. And then right after that, we will be doing the draw for your book. So you have the hard copy of the book, right? Okay, and so what we'll do is whoever wins the book, we'll get their address and send it to you so you can send it out. And if you can let us know when the audio has been launched, I'm sure that we can get that circulated through OHCOW and our labor councils.
Okay, great. Thank you.
Thank you. So I'd like to now invite Sean McKenney, President of the Ottawa District Labor Council, to give some closing remarks.
Thank you, Laura. So, this was great, and anytime, and I know that we've been doing the Zoom stuff for the last couple of years, all of us have. So anytime we see the number really close, the number at the end of a meeting or a session, an event that lines up to the number at the beginning, it was fairly successful, and we're really close. We lost a few folks, and that's fine. And I think the topics, the speakers were amazing, in respect to Daryl speaking about the concussion piece, and Trevor talking about the shoulders, and then of course Jim and Margaret. The thing that frustrates me all the time with these kinds of events is, man, the number of people that could benefit if they participated in the session. It just blows my mind, because there could be such a positive gain. Margaret and Jim talked a lot about letting people know and getting the public on side. I think if one thing for sure that we've seen is that the pandemic has shown us the deficiencies within that healthcare system. And even though I am a union member, proud, and I've been doing this kind of work for a long time, those that are active, whether they're in unions or with health coalitions and others, I'm going to suggest that we're not the best communicators, because we're right, and what we have to say is a fact. Yet there are so many people that just don't understand. So it's not a question so much of making sure that the public is aware of what's happening with the healthcare system. It's a question of, we need to make sure that we have some effective strategies around communication so that people can understand. It's not just getting the knowledge out, because, and it's not through their inability to comprehend. It's just everybody's busy. So we have to figure out a better way of messaging folks so that they truly understand. And the point about getting the public on side, we get the public on side, we get the politicians on side, whether at a municipal, a provincial, or a federal level. So it's win-win-win-win all the way around. Again, I really enjoy these sessions because there's so much information. Again, the frustration is we're really happy with the number. That's not the piece. The piece is that even with the 45 to 50,000 people that this Labor Council represents, that all of those couldn't benefit from this kind of session. That's the frustrating part for me. But anyway, again, thanks to the presenters, and thanks to all of those that participated in the session today. I think it's been great, and thank you so much for participating.
Thanks, Sean. And on behalf of our OHCOW LAC and our great OHCOW staff across the province, not just in our own LAC, and all our labor councils who've been working together to support these events over the past few years, I would just like to extend another great thanks for all the hard work they do every day, and particularly helping to put these sessions together. Kimberly, would you like to say a final bit of comment before we do our selection for the book?
I sure would, and it's again echoing what you have said, but my absolute pleasure to thank both Laura and Sean. The support from our local advisory committees is what makes OHCOW successful, and Sean and Laura have been with us since the clinic opened in the East. And the Ottawa District Labor Council, again, joint, our partner, putting this event on, which has just grown and grown. We can't wait for it to be back. We hope there's a hybrid, because like I said, I don't know if we'd get the people up the line to come to Ottawa on this day, but we'd love to be with you in person, and we want to hear more about that in the evaluation. So yeah, just a big thanks to our LAC and our partner, the Ottawa District Labor Council, and reaching to other labor councils in the Eastern Ontario. It was one of the objectives for the local advisory committee and ourselves today. Our leadership, we're a labor governed board. Today we have board members with us that are in Toronto. We are so grateful. We have system partners from the ministry. We have other LAC members. We have We're just so very grateful. Spread the word. That's, I guess, the parting words are to help Jim and Margaret and our other speakers, Daryl and Trevor, and be advocates. Be, as Sean said, if people can't make it, there's a recording. You can share this with your joint health and safety committees later. If now is not the time, that's the beauty of some of this technology, is there may be another time where some of this is pertinent to you. So stay tuned to have the recordings and share as you will. So to David Chezzy, who leads us out as president and chair of that board, we are grateful. To all the speakers, Daryl, Trevor, Margaret, and Jim, to our fearless Jennifer Moore and Cheryl Baker, who make sure all this happens. So grateful. And to the rest of our team in the Ottawa clinic. Some couldn't make it today because they're off fighting COVID or in other sessions. But Tracy Feener, Snow, Cheryl, you already met, Todd Irick, Kevin Hedges. I just wanted to introduce you, even just by name, to the team that supports you, Dr. Bourgault, Dr. Wills in the Ottawa region. And we hope to meet you in the clinic face-to-face someday soon when all of this passes. And I did throw some resources in the chat. David knows I generally take people to the website, but I won't do that for you today. I put the links in there. There was some, as people were asking questions about ventilation and respirators, I threw some of those links in there, as well as when Daryl was talking about hazard assess, and as subject matter came up, I tried to put links in the chat session as well for you all. So really, really appreciative, and thank you for coming this morning.